So, last of all, welcome back, Lisa. For those of you who weren't here before, Lisa Beach is a senior physiotherapist in the intensive care at Royal Melbourne Hospital and the cardiorespiratory physiotherapy team leader. She completed a Bachelor of Physiotherapy at La Trobe University in 2005 and her Masters in Physiotherapy Cardiorespiratory at the University of Melbourne in 2011. She has over 12 years clinical experience, predominantly in the cardiorespiratory physiotherapy. Lisa's research interests include physical activity, early rehabilitation, outcome measurement, and functional outcomes for patients admitted to the intensive care unit, and she has a number of publications in the area. Thanks again.
Thank you, and apologies to those of you who had to listen to that introduction twice. This time I'm going to be presenting on the results of a survey evaluating multidisciplinary staff satisfaction with the ICU Physiotherapy service, and I would like to acknowledge my co-authors for their assistance in this piece of work. So in 2016, the Royal Melbourne Hospital ICU expanded from 24 to 32 beds and moved into a new state-of-the-art facility. In 2016, prior to the move, the physiotherapy staffing ratio was well below both published recommendations and national benchmarking data. Published recommendations stated that 2 physiotherapists per 10 funded ICU beds was appropriate. In our national benchmarking data, which included only level 3 ICUs that were also tertiary trauma centres, the highest physiotherapy ratio to 10 beds was 3.3, and on average units had 1.5 physiotherapists for every 10 beds. At that time, the RMH ICU had less than 1 physiotherapist for every 10 beds. In addition, a 7-day service and an after-hours evening service is routinely recommended in the literature. And this was reflected in our benchmarking data where over 90% of respondents reported having the availability of a weekday evening service. So in 2016, our physiotherapy staffing increased in line with bed growth and in response to benchmarking data and also published guidelines. So prior to this change, we had 1 physiotherapist for every 13 beds during the week, and this improved to a ratio of 1 therapist to every 5 beds. And on the weekends, we had 1 physiotherapist to 24 beds in the old system, and this increased to 1 physiotherapist to 11 beds. We also subsequently implemented an evening service, which was available until 7 p.m. on weekdays. So the purpose was really to evaluate the impact of our new model of physiotherapy care. We wanted to determine whether our new model of care and service delivery was meeting staff needs and expectations, and to identify areas where we could improve our service provision. And this will complement other quantitative patient data evaluating the impact of our new model of care. So specifically, our aims were to determine multidisciplinary staff satisfaction with the previous physio service in 2016 and the current physiotherapy service we have today in 2018. And as I mentioned, identify how we could improve our service. This staff survey was developed by the research team with input from medical and physiotherapy staff. It was designed based on published guidelines and piloted on nursing, medical and allied health team members and feedback obtained. The survey included 14 questions on a 5-point Likert scale, rating staff satisfaction from strongly agree to strongly disagree with a number of statements. The survey was administered to nursing, medical and allied health staff working clinically in the ICU, but we chose to exclude physiotherapists. It was a convenient sample conducted at 2 discrete time points to clinical staff present at one day in May 2016 and on a single day in March 2018. These are some examples of the questions we included. I am satisfied with the current weekday physiotherapy service in the ICU. Physiotherapists see patients as frequently as I would like. I can access urgent, within 1 hour, respiratory physiotherapy care for my patients in the ICU on weekdays. I can access physiotherapy in the evening after 4 p.m, and physiotherapy staff participation in research activities is adequate. Here we can see on the left-hand side our response rate. In 2016, 28 surveys were distributed, and in 2018, 39, the higher number being reflective of the larger unit size and therefore more staff working. We had a good response rate with 79% of surveys returned in 2016 and just over 82% in 2018. On the right-hand side, we can see the breakdown of respondents by profession, the higher number of nursing staff respondents being reflective of ICU workforce. And this was out of a pool of more than 300 ICU staff. I'll attempt to use the pointer on this slide. So in terms of staff satisfaction with the physiotherapy service, down the bottom on the x-axis we have satisfaction on weekdays in 2016 and 2018, and on the right-hand side we have satisfaction with the weekend service. On the y-axis we have the percentage of staff who either strongly agreed or agreed with the statement that they were satisfied with the physiotherapy service. Satisfaction improved from 82 to 91% on weekdays, and there was a larger increase in satisfaction observed on the weekend from 41 to 71%. There's a similar setup in terms of this graph down the bottom. Once again, weekdays on the left-hand side and weekends on the right-hand side, and the percentage of respondents on the y-axis who either agreed or strongly agreed that they could access urgent respiratory physiotherapy. Satisfaction improved by almost 20% on weekdays, and we saw an increase from 32 to 42% on weekends. Some responses to some of the other questions are included in this table. So physiotherapists can see patients as frequently as I would like, increased from 55% to 88%. Physiotherapists can see patients multiple times per day when required. So in 2016, half the staff either agreed or strongly agreed with this statement, and this improved to 81% in 2018. Physiotherapists provide all the services I feel are indicated. This was at 59% in 2016 and improved to 88% in 2018. And physiotherapy participation in research is adequate. So only half of the staff felt that this was the case in 2016, and we actually saw a small decrease in this number in 2018. And at both time points, a high proportion of staff neither agreed or disagreed with this statement. In terms of access to after-hours physiotherapy, along the x-axis we have the responses from strongly agree to strongly disagree, and on the y-axis we have the percentage of respondents. On this graph, blue represents 2016 data and red represents 2018 data. And it's important to remember that in 2016 there was no evening service available. A permanent evening service was implemented in April 2017 following an evaluation of the need for this, and one staff member is available until 7 p.m. on weekdays. As you can see, there was an improvement in or a reduction in the number of staff that disagreed that they could access evening physiotherapy between 2016 and 2018, which is a good thing given we introduced the service. However, there's still quite a large proportion of staff who neither agree or disagree that this service is available and may indicate a knowledge gap regarding it. So we had a good response rate to our survey, and it was representative of the size of each professional group working within the ICU. With improved physiotherapist to bed ratios, we were able to improve staff satisfaction with the overall service and their ability to access timely, comprehensive physiotherapy review and an appropriate frequency. We had comparable improvements in physiotherapists to bed ratios on weekdays and weekends. However, overall satisfaction with the service increased more on weekends, where we previously had very poor staffing levels. The availability of physiotherapy evening service and physio participation in research may need to be further explored. Perhaps we need to increase knowledge regarding availability of our after-hours service, and in terms of research we may need to look at whether are staff aware of what physiotherapists are doing. Do physiotherapists genuinely need to do more research, or do we need to look at the type of research we're doing and maybe have more of a multidisciplinary focus? This survey was only conducted at one time point and only included a very small proportion of our overall ICU staff, and therefore we can't be sure that these opinions are reflective of all staff working within our ICU. So in conclusion, we found improvements in satisfaction with our expanded physio service, particularly on weekends and after hours. Further education may be required regarding availability of that after-hours service, and further promotion of physio involvement in research and ongoing participation may be warranted. Thank you very much.
Thank you, Lisa. Any questions?
Thanks, Lisa, for a great talk. I was interested that the results show, obviously, that the staff are generally really satisfied with the service, and you've had a lovely increase in staffing numbers. Is any of this supported by improvements in patient outcomes like reintubation rates, time to mobility milestones to support that improved satisfaction?
Yeah, that's a good question, Kate. We haven't looked specifically at those types of outcomes as yet. We have, obviously, from some of the previous work I presented today, looked at that small cohort of patients who do develop ICU-acquired weakness, and we've seen we can provide them with more therapy, but we didn't actually see significant differences in their outcomes. We are also collecting some data regarding our unmet needs for all the allied health professions within the ICU, so looking at how many patients that we're still actually not able to see and what the priority of those patients are, and any barriers to providing them with care. But that would be a really useful thing to evaluate.
Thanks, Lisa. That was really good. Just a quick question. With the limitations of the study, why did you choose, if you had a pool of such a large number of greater than 300, why did you choose to evaluate it at that one point?
Yeah, that's a good question. More from a logistics point of view, we have quite a lot of difficulty with nursing staff regularly accessing email in our unit, and they don't sort of regularly use it. So we felt that distributing an electronic survey may actually result in a poorer response rate, but we may have actually been able to capture a larger number of staff by doing it that way. And we were also, when we did the initial survey, on quite a tight time frame in terms of working in around our move date.
Any more questions?
Lisa, what do you think, from what you've looked at and given that you've done benchmarking, do you think is the adequate ratio of physio?
Yeah. Certainly, I think the improvements that we've seen during the week, I think the nature of physiotherapy work within ICU has changed over my working career. Whilst we still have quite a significant role in the respiratory management of patients, I think that is a little bit less of a focus and more of a targeted focus now, and an increased focus on this early mobilisation, which is more resource intense from a staffing perspective. So I think certainly a ratio of 1 to 5 appears to be appropriate during the week. There are still a number of patients that we are not able to see regularly. I think we could definitely improve our ratios on the weekend though as well. And we also have in our workplace some guidelines around the number of what we term double treatments that require 2 or more therapists that are quite manually handling intensive that each physiotherapist should complete on a daily basis. So that also impacts on the number of sessions that we can provide these quite dependent patients.
Thanks, Lisa. One more question?
Hi, Lisa. Just a quick question. When you have a ratio of 1 physiotherapist to 5 patients, essentially that ratio, are those physiotherapists just in ICU, or do they also cover the wards? And then I suppose when you talk about unmet need, then does that have a factor where if they're on the ICU more, there's more unmet need on the ward and back and forth?
So this is a dedicated ICU physiotherapy team. So there's 6.4 staff that service the ICU on the weekdays, and that's a mix from, sorry for those not in Victoria, from grade 4 down to grade 1. So a range of expertise. We do occasionally, the ICU team work as part of our more broad cardiorespiratory team, and we certainly do look at workload allocations across our team on a daily basis and assist as required, but predominantly that team are dedicated ICU staff.
Thanks very much, Lisa. That brings our session to an end. I'd like to thank the audience for some fabulous questions, and also especially thank our speakers for very thoughtful presentations, very interesting, and it's great to see an allied health session at this ANZICS conference. So congratulations to you all.